So I'm going to go through the publications that have come out and things that are coming since the last meeting. So the first thing was simultaneous to the family meeting last time, we had a big research conference. So we had almost 100 doctors come from 10 different specialties, U.S. and international. And the first part of the meeting was a small session really to hash out the diagnostic criteria that Dr. Gerlay drafted. That's the closed door meeting that Dr. Frieden said we locked her into, which we did not do that. And then that was presented to the larger group, and we had specialists from every organ system talk to the doctor group, and we had discussions and talked about research projects and all of that. And so that was about a day and a half, and the main publication that came out of that is this one, PHACE Syndrome, Current Knowledge, Future Directions, which is basically a summary of that entire meeting. It's a resource document. It's about 14 pages long. But if you have a physician who really wants to know up-to-date information on whatever organ system or the discussion questions, that's a really nice reference to have. And by the way, I don't have a handout because I was putting this together at the last minute because I wanted the latest stuff in here. But if you want one, just email me. I'll give you my email at the end, and I'll send it to you. So that was published in Pediatric Dermatology. That's our main PD-Derm journal the summer after the meeting happened. The other publication from that meeting, I'm going to go over this one more time. I know you've heard about the diagnostic criteria, but I think this was a really pivotal move forward with PHACE syndrome, and this was published in Pediatrics. There are two main pediatric journals that go out to all pediatricians and pediatric subspecialists, and it's this one and Journal of Pediatrics. So this came out in November of last year. And the reason that this is so important is that before, our definition of PHACE was facial hemangioma and anything else wrong with your child. So there were tons of cases out there of kids that had problems that were just probably normal, what we call normal variants, things that are common to the normal population. And so the ability to really tighten up people that we call PHACE, our study cohorts, is going to make our data so much more accurate. So I think this is really, really pivotal. As you guys know, the diagnosis of definite PHACE means you have to have a large head and neck hemangioma and one of the major or minor criteria that you've probably seen. But we didn't want to rule out the fact that you can have hemangioma that's segmental in some other location, like the chest and arm, or even no hemangioma and still possibly have PHACE. So that's the reason there's this possible group. Or if you have a large facial and two minor criteria, you can meet diagnostic criteria. So that's possible. And we talked about what that's going to do, just improve our diagnostic abilities and also our study results, for sure. Okay, I'm going to talk about a few studies that just came out last month. This is a big one that was published in Pediatrics last month that was really asking the question of, okay, you have a child come in with a large facial hemangioma, what's the risk of PHACE? And what is that risk? Do y'all know that number percentage-wise? It's about 30. So what we did is we enrolled 108 infants, and it's the first time that we had a study cohort where we screened every single one of those patients completely for PHACE. So they got head and neck imaging, heart imaging, and eye exam. And 31% of them met the new diagnostic criteria for PHACE. So our previous numbers, we said, it's probably a 20% risk if you have a large facial hemangioma of having PHACE, so it's really higher than we thought. We also had previously quoted that, it's most common to have a child with a large facial hemangioma and PHACE who just has one other extracutaneous or non-hemangioma finding. I think that may have been a result of including all these other kids who had kind of normal variants, because in this study, the vast majority had more than one finding besides the hemangioma. We also, this is something that we had a feeling about for a long time, that the larger the hemangioma is on the face and the more extensive it is, the higher the risk. And we did show that in the study to be the case. So the more extensive the hemangioma, the larger, the higher the risk. And also, we've also suspected for quite some time that if you have a hemangioma in this region, the segment 1, or this region, the segment 4, that you are more likely to have brain anomalies. And that was actually, segment 1 was the most common segment involved in this study. In contrast to that, this segment, the segment 2, cheek, seems to be at low or no risk of FACE if you just have that and nothing else. Or this region here, the segment 3, the mandibular, those patients seem to be at higher risk for cardiac problems, sometimes the sternal problems, but also a significant number of those children had brain anomalies as well. We also, for a long time, we've said, oh, the most common anomaly in FACE syndrome is Dandy Walker. It's actually not true. By far and away, the most common anomaly in FACE are the cerebrovascular anomalies. So in this study, 91% of those patients had cerebrovascular anomalies, most commonly of the carotids. And that's why we emphasize to you guys how important it is to image not only the head, but the neck with the MRI and MRA. And this is higher than we thought previously. Almost 70% of patients had cardiac anomalies, and almost 10% had coarctation of the aorta, so higher than we thought previously. Okay, another article that came out last month in the archives is Dr. Jolet, and I've submitted a case as well, is the Association of Hearing Loss with FACE syndrome. Who of y'all has a child with hearing loss associated? So a few. So, and Lily's one of them, actually, included in this. So this study describes 6 infants with FACE syndrome and hearing loss. And what we noticed in this study is that the patients who had hearing loss had very typical hemangiomas and a very typical distribution. So if you look at these pictures here, they all had segmental hemangiomas that wrapped around that ear and involved the scalp as well. So usually the ear was involved and the surrounding scalp too. So very similar distribution. I think we've talked about the fact that we want to map out the scalp hemangiomas. We think that these patients are at high risk, and we need to do that. That's one of our planned studies. And the cause of the hearing loss varied in these patients. So some of them had what's called sensory neural hearing loss. That means you're born with hearing loss. It doesn't change it over time. It can't be treated with medication. It's just there for life. A fair number, though, also had conductive hearing loss because of a hemangioma inside the ear. You can actually see that. That's a hemangioma in that circle in the inner ear. And so we recommended that patients get MR imaging, which we are already. And they also follow that with hearing testing because, of course, the newborn hearing screen can often be passed by these babies because the hemangioma hasn't grown yet. So something that to be aware of and just to look at. This is Dr. Hess's study that came out also last month in the American Journal of Neuroradiology. This is the largest neuroradiologic study of FACE syndrome patients to date. He looked at 70 patients. You know, he talked about this in his talk as well. Beautiful job explaining things. But what he found was that most of the anomalies were arterial. We knew that. Arterial anomalies in FACE are the type of anomalies we see are very unique to FACE. They're found in very few other things. He also found most of the anomalies were anterior, so they tended to be carotid anomalies. They tended to be on the same side of the facial hemangioma. We know in that correlation, same side of the hemangioma, the anomalies underneath it, they tend to correlate. So that was a really important study. This study, looking at GI bleeding as a complication of hemangiomas in the GI tract, is in press and was presented as a poster at our pediatric derm meeting in Portland in July. Who has a child who's had GI bleeding? Okay, just one. Pretty rare condition. But this report looks at 6 girls who presented in infancy with severe GI bleeding and who also had GI hemangiomas in the GI tract as well as a facial hemangioma. 5 of the 6 had FACE syndrome, and interestingly enough, all 5 also had coarctation of the aorta, so there seems to be a relationship there. Does your child have coart? I think that's right? And they also had arterial anomalies within that area, so in the gastrointestinal mesentery, in the chest area, and the neck. So I think this is really rare, but the point of the article was that if you have a child who's got GI bleeding and has a skin segmental hemangioma, you need to think about hemangiomas in the gut being a cause. And the other thing that was noted is that GI hemangiomas are really difficult to diagnose on just regular imaging that's typically done, and often some of these secondary imaging techniques are needed to diagnose this. Okay, this is a study that is in press for the Journal of Otolaryngology. And the purpose of this study is really to alert ear, nose, and throat doctors that when they see a child who's got an airway hemangioma and a facial hemangioma, they need to think about face. So in the pediatric dermatology world, I would say most people know about face. In the dermatology world, I'd say probably most dermatologists have heard about it. But outside of our scope, there's still many, many doctors out there who've never heard about face. So you guys will see in these publications that we're trying to publish in areas other than derm, pediatrics, ENT, neurology. We're trying to get the message out there to more physicians. In this study, we looked at 17 infants who all had large facial hemangiomas and airway hemangiomas, and we fully evaluated every patient, and 50% of them had face, so a really high number. The hemangiomas that are associated with airway hemangiomas usually are mandibular, that S3. They're often on both sides, but they also can be kind of these big, extensive unilateral ones on one side of the face. Sometimes they're just a little small hemangioma of the lip or the chin, and sometimes it's just this minimal growth that I'll show you in a minute where there's just not much thickness that happens with hemangioma. It just stays relatively flat. And so the conclusion was, for the ear, nose, and throat physician in particular, where this is targeted, that if you see a child, again, airway and skin, to think about face. Okay, and then a couple of smaller studies. This is just to explain that we are always learning new things about face. And I have a particular interest in the outlier, those children that don't quite fit the mold, because I think those are often the ones that teach us the most. So every time you guys tell me something unusual or different, we pay attention to those things. And this is a child that I saw. He presented at birth with congestive heart failure, and then immediately after birth had to go for evaluation and emergency surgery. But he ended up having what's called an AV malformation. It's a rare type of an arterial anomaly that's very high flow and can be very complicated. And we haven't really seen this much in face to date, but this child had that, and also a hemangioma that wrapped around the scalp, just going back to that scalp involvement, we think being a risk factor for especially arterial anomalies. Let's see if I can point this out. And Craig, if I'm totally off, you can yell at me. Because I don't know about you guys, but Dr. Hess, he explained, his talk was just so, I loved the way he presented it. I wish somebody had explained that to me the very first time. It would have saved me a lot of grief. But when he was showing those pictures and asking you what's missing, I didn't get that at all. I don't know. I don't know about you guys, but I guess I don't have that kind of a brain. I couldn't figure out where he even was. But anyway, you can kind of, I don't have a pointer, I don't think, or where, oh, it's here. So this area here, kind of tangled vessels, and here in this area, and here is all this AV malformation. And we think we looked at 2 infants that were patients of ours who had this association and also met diagnostic criteria for face, and found 3 other reports in the literature. And we really do think this is related, and it's just kind of a heads up that our diagnostic criteria are pretty specific, but we're going to make updates, I am sure, to those criteria over time as we continue to learn more. Okay, this minimal growth segmental facial hemangioma and face syndrome, somebody asked about that. A minimal growth hemangioma is a hemangioma that really just doesn't raise up very much. So sometimes you'll see kind of a flat stain that may get a little bit of growth on the periphery, the sides, like little bumps, or along the eyelid or on the lip. Or sometimes it looks more like this, where it's just looks like little broken blood vessels, and it just stays that way. It doesn't get thicker. And the main point of this article is to alert people that this is still a hemangioma, because I think when people think face syndrome now, they think of that big plaque on the skin, on the face, and the hemangioma is not always like that. Sometimes it can be like this. So in this study that I need to finish, we reviewed 9 new patients and 13 patients who were in that big 108 group. And again, we just really want to demonstrate that hemangiomas in face are not always that typical plaque. It does not seem like this type of hemangioma puts you more at risk for face because they all had the typical distribution and extent and segmental pattern. And it doesn't seem like this group is at higher risk for cerebrovascular anomalies, but it's a small group, and so it's not what we call statistically significant. It didn't factor out as being significant, but I need to, this is still in progress.
Are those kids on medication?
Oh, the question is, are those kids on medication? That was the other hard part about this study, because trying to decide, was it really a minimal growth or did they get on medication? And it looks like that. So these were all children who, at 3 months of age, had not been on medication, and the hemangioma showed no evidence of proliferation. Okay. Anything outside of that category, if they've been put on medication before, we excluded those. Okay. But that was a tough one. It is. Some of you all know that I run the PHACE Registry in Houston, so it's really important to enroll if you haven't done this, because most of the studies I just talked about used information from the registry. Like everyone who's in the registry, all your data went to Christopher Hess. It's all going to UCSF for the neurocognitive study, so it's really important to us that you guys enroll. And I just wanted to say, first of all, talk to your friends in the room. It's pretty easy, right? You guys have done it. It's a questionnaire, consent form, and you just send me a picture. And you can email me if you don't want to go online. Just email me. I'll send you the forms, a self-addressed envelope, anything to get those forms back. The second thing is, Carla talked about privacy yesterday, and I think that's really important, especially with medical records. I just want you to know that when I get your information, it's de-identified right then. So your child's information is assigned a number, and from that point on, that information is only known by a number. Your child's name is not linked to it in any way. So the only person who knows your child's name other than me is Dr. Siegel doing the genetic work. So everything else is de-identified to everybody else, okay? So I think it's really important for this, and also to donate blood or tissue for Dr. Siegel's study as well. Okay, so the last, when we start, Beth, all day Wednesday and Thursday morning, we met the physicians in a smaller group this time, because we've done kind of the more bigger stuff already. Now we want to narrow in our research to more targeted things. So it's a group of maybe 20 of us, I guess, Beth, or so, that talked about where we need to direct research at this point. This was directed by Dr. Jolie. The first thing that we did is Kimberly, who's up at the top row there, put together a beautiful review of stroke cases. And so to date, these are either published reports or reports that we know of through our group. There have been 20. The average age range is 3 months up to 17 years, but the mean is 11 months and the mean 26 months. So going back to that, most of the children falling into that kind of infancy, toddler category of when they stroked. Surprisingly, a very high number of the patients who stroked had aortic arch anomalies. We're not sure what the correlation is exactly there, but that was significant. Most of them had a hemangioma of S1, and most of them had internal carotid artery anomalies, but again, S1 is the most common location to be involved overall anyway, and the internal carotid artery is the most common artery to be involved. So that's not abnormal compared to the overall group. What is specific is that 95% of those patients had either severe narrowing or non-visualization, usually of their internal carotid artery. So what we want to do is we realize that, we've all seen a lot of these patients. We know that there's a large number of them that will never be at risk for stroke. There's it seems like a pretty small proportion of children stroke. And so what we want to do, and then there's also a pretty big proportion of children who are not risk-free by any means, but will go on and lead pretty normal, healthy lives. So what we're trying to do is stratify patients into risk categories. So either a standard risk, kind of the norm, or what we call high risk, either from a stroke standpoint or a neurocognitive delay symptom standpoint. Now, that sounds really easy when you look at that, but it was hours of talking together in small groups, breakout sessions, and it's hard to do that because I think we all kind of know when we see a patient who's going to be on the severe end, but trying to write that down exactly and be specific is difficult. So I can say we got some preliminary documents together, but they need to be shared with other specialists, neurology in particular, stroke specialists, and we're going to hash that out and hopefully we'll get that done. So that I think will help us answer the question of that you guys had of, well, who needs to be imaged frequently and for how long? You know, do we need to be doing the serial imaging on every single patient? The answer is no, but we need to identify that group that needs it. So this is an effort to try to do that. Okay, does that make sense? Okay. We also, as Craig had mentioned, we want to develop standardized imaging protocols for patients. So the radiology world is very foreign to me. All that there's lots of studies, there's lots of ways to do them. And especially if you're not in a big academic center, those physicians, you know, out in more rural areas have a really hard time deciding, knowing what type of imaging to do for a FACE patient. So I think Craig and his colleagues are trying to hammer out what's the safest, most inclusive, timeliest study that you can do for a FACE patient and get, you know, the most bang for your buck kind of thing. So we hope to get that out too. And then the last thing is developing what we call anticipatory guidance. That means your child goes into their main caregiver, their coordinator of care, which might be their pediatrician or whoever, and that pediatrician knows, okay, these are the questions I need to ask your child at their well child check. These are the things I need to look for, that kind of thing. And we feel like that will be very important for our patients as well, because pediatricians have to know about so many things, you know, so many disorders. So we want specific guidelines for FACE. Okay, things that we have right now in progress. 2 neurocognitive studies going on. One is with Dr. Jolie, where she's doing formal neurocognitive testing on patients from ages 4 to 6. Is that still right, Beth? She has 13 patients enrolled already. I would highly encourage you, if you have a child in that age range or know someone back in your hometown, to make that visit if there's any way possible. Just trying to collect that data and correlating it with imaging findings. There's also a study going on in San Francisco looking at children with FACE who have had formal neurologic evaluations and or symptoms, and trying to correlate that with imaging findings as well. So hopefully we can get you more data about, okay, are the developmental delays, the speech delays, the motor delays, are those really secondary to structural brain problems? Are the seizures due to vascular anomalies? Are they due to structural anomalies? We're going to try to help answer those questions if we can. Things that are planned, I think from everything that Carla's told me, and then she's had feedback from you all, we need to look at this migraine headache issue more closely. We know it's not uncommon. I've heard that from quite a few of you at this meeting. The headaches are severe, often the nausea, vomiting. Jennifer was telling me they can last for up to a week, really debilitating. It seems like the age of onset seems to be around that preschool age, but maybe it's because, you know, kids just can't verbalize anything before then, so we just don't know. We'll have to look at that. If there's any way to look at long-term outcomes, if we've got older patients, you know, I know I have one who had them in younger childhood, now doesn't, but I don't, you know, that's one patient, so we'd like to know that for more patients. We want to collect our experience to date using propranolol and FACE. So I've had quite a few patients with FACE on propranolol, but we all worry about that select group that's in that high-risk group, and what's the best thing to do for our patients. So we're going to just collect our experience and put that together and look for side effects and imaging changes and anything else that we can put together. We want to map those scalp hemangiomas and try to assess risk. We need to look more closely at family history. As Dr. Siegel mentioned, you know, there's to our knowledge, there's never been more than one family member reported with PHACE. But what we haven't done a good job, I don't think, of asking is whether other family members have seizures or, congenital heart disease or headaches or anything that could be related. So you all will probably be getting asked again about family history. And then something I'm interested too is this, I don't want to call it hypothermia necessarily, but this temperature instability. I know I have, and what I'm talking about is these episodes. Jennifer told me she's experienced something similar with Grace, where the child suddenly turns blue and it feels cold and looks, is cold to touch. It goes to the emergency room, or the nearest caregiver is worked up fully, and nothing etiology-wise can be found. It doesn't seem to be anything neurologic. It's not stroke. It's not a seizure. It's something different. And I was trying to remember which family member at the last meeting brought that up. That's what I was wondering. Was there anybody
Grace
else?
never felt cold.
She doesn't.
No,
but just
sometimes
blue
when
lips.
she would go from like a bath to getting out, the shock of maybe being cold.
Okay.
But she never felt cold to the touch. No.
Okay.
Izzy was treated
But
at the hospital for
That's what.
hypothermia.
Okay. And then.
I
Jen.
didn't, but
And
it was
Elise.
the opposite.
Yeah, that's.
It's called maybe like an autonomic nervous thing,
Uh-huh.
where he gets this cooling and his legs go red and he gets this rash. His arms go red, and it's just they've never been able to figure out what it was.
Does that still happen?
Yes.
A couple people have told me too that their children, maybe this isn't anything, but they seem to be more heat sensitive. Like they'll actually get sick when they get hot. Maybe you guys, anybody seen that?
Elise used to get really sweaty before.
Okay.
And then now she turns really purple in her hands and her face. Just gets really purple and cold.
Okay. So.
If I take her temperature like that, she's usually 92, 93, 94, and we just wrap her in warm blankets, because going to the ER just equals hours of sitting there with warm blankets.
Okay. And
blood
nothing on
draws.
EEG or
They did
head
blood draws,
imaging or.
but she had like some elevated things that they couldn't really connect anything to. I can send you the report,
Okay.
but they couldn't connect anything.
Okay, so I'm trying to remember if he said that. If I contact you guys at some point. Okay. Also just want to say what an honor it is to be here again, and I also wanted to give some credit to Beth, more than she gave to me, because I think sometimes you don't get the credit you deserve, but she really has done a huge amount of work for this meeting and a lot of preparation, and I know how much that takes, and has done a whole lot to try to advance our knowledge in PHACE syndrome too. And Dr. Frieden mentioned lag, but I don't think that has anything to do with it. I think it's all hard work by far. So thank you, Beth, for everything. And it's great to be here and see you all. And we're working hard. We really are. A lot of it's behind the scenes, as you're seeing, but I think we've learned a tremendous amount from even 5 years ago, even 2 years ago. So hang in there with us. We're trying to get answers for you, but we don't want to give you false promises either, or tell you something we really don't know either. So please, thanks for your patience.